This year the ASCO was opened by the Gynecological Oncology session, and the first two abstracts were on surgery in ovarian cancer, and I think we saw data of practice-changing data from two big studies on this issue. The first one was the LINE study, which is a study in primary treatment of ovarian cancer, and the question addressed was, what is the role of lymphadenectomy in patients with ovarian cancer, and especially in the subgroup of patients where you have no clinical suspect lymph nodes. In many countries, these patients receive the lymphadenectomy in case of staging or debulking surgery, and the role of it was not completely clear. So what we performed was a phase 3 study, randomizing patients during the operation, and if the patients had no residual tumor in the abdomen, then we checked all the retroperitoneal lymph nodes. And if they were not suspect, then we randomized patients to receive a lymphadenectomy or not. And that was a very big study with 640 patients all over Europe. And the final analysis was presented now, with including overall survival data and the final conclusions. We found that the patients did not benefit from lymphadenectomy in that clinical situation, so we could, in the future, we could omit this part of the operation. This part of the operation adds another 1 hour of surgical procedure duration, with more blood loss, more transfusion, and more morbidity, and that was significant. So from now on, we can change the guidelines, omitting this part of the surgery in this subgroup of excellently operated patients, and then we can save morbidity to these patients. So life will be easier, both for the patients and for the surgeons in that subgroup. However, the prerequisite for that is that you have an excellent debulking surgery without leaving any macroscopic tumor behind. So the Desktop 3 study was a prospectively randomized controlled trial following Desktop 2 and Desktop 1. This is a series of trials evaluating the role of surgery in recurrent ovarian cancer. So with Desktop 1, we started to evaluate a score helping to identify patients who may benefit. In Desktop 2, which was also a prospective international trial, we confirmed this score, that this score could help to identify patients with a high probability of having at least a complete resection, whatever that means. And Desktop 3 was then the prospectively randomized trial to evaluate whether this complete resection translates into meaningful clinical benefit. So we randomized 408 patients into that trial, selected by this AGOR desktop score, which consists of 3 points, namely performance status, result of prior surgery, and ascites. And these scores selects about half of all incoming patients with recurrent ovarian cancer. And these patients were randomized to receive surgery or not. Both arms then had their platinum combination therapy. And we could find that the surgical arm provides a clinical, significant and meaningful benefit with respect to progression-free survival of about 6 months, and for time to third-line treatment of 7.2 months, which is in this disease, in this stage of disease, a meaningful benefit. And the benefit was exclusively seen in those patients with a complete resection, indicating how important it is to select the right patient and the right center. We selected all centers, and only those who are capable of performing these complex operations should do it. But then the patients have a much better prognosis than before. I think this year's ASCO shows a few things. One is that we as Europeans are able to perform practice-changing trials in this part of gynecological oncology. It's dominated by European groups this year, and even more interesting is that we not only can do chemotherapy trials to give treatment A or treatment B, but we are also able, within a very well working cooperation in Europe, to perform surgical trials, which are much more difficult than other trials. Fortunately, we have in Europe such a network, which is the ENGOT network, that brings together people who really put effort in also answering the difficult questions.